Good afternoon. I'm delighted to be here and to be part of the Gein's lectureship. I've had the pleasure of going to the internet and learning a little bit about the foundation and some of the wonderful philanthropic work that it has done, and it's extremely impressive, as is the list of speakers who have preceded me and who have talked on a broad range of controversial and stimulating topics. And I hope that today's will meet the challenge that the others before me have presented. I'm going to be talking about family caregiving, and what I hope to do is demonstrate that we have a triad: caregiver, care receiver, and physician, and that no one of these individuals actually finds their role particularly easy to handle. Just brief acknowledgements. I've listed on the screen the organizations that have kindly funded my research in caregiving: Health Canada, New Horizons for Seniors Program in Canada, Heart and Stroke Foundation of Canada, my own hospital, St. Mary's Hospital Research Foundation, and the Pfizer Foundation that provided an unrestricted grant for some caregiving research. I have no conflicts of interest except for the fact that I am a caregiver. Unfortunately, 5 members of my family have had chronic neurodegenerative diseases, and as such, when I talk about caregiving, I'm going to be talking not only as a clinician, not only as a researcher, but as somebody who, in the vernacular, has the lived experience of being a caregiver. Perhaps first a few definitions to make sure that we're all on board. In Canada and in the US, the original term for somebody who looked after somebody at home was an informal caregiver, that is, somebody who was non-paid. And then that term gradually began to disappear as the people at home said, wait a minute, we're more than informal, we are serious, hardworking, dedicated people, and the term family caregiver came into being, and shortly thereafter the term caregiver became the more common terminology. And in my slides you will see CG, that refers to caregiver, CR will refer to care receiver. In the United Kingdom, Australia, and New Zealand, they've simplified it and they're referred to as carers. In French-speaking places such as France or the province of Quebec, where I come from, the term is aidant naturel, which means natural helper. And interestingly, in France, they have actually created a discipline related to caregiving, and it's called proximologie. Proximologie coming from the Latin word proximus, the state of being near to. Or for those of you who are any good at Latin in anatomy, you will talk about a vein being proximal to an artery to a vein, and so forth. And so they have developed their discipline based on the idea of being close to somebody. In thinking about being close to people, I'm at a bit of a disadvantage today in that you heard a little bit about me. I know nothing about you. So I'm going to take a very quick census here. How many of you are health professionals? Of the health professionals, how many are doctors, nurses, physio and occupational therapists, social workers, a good number, residents and students who haven't identified themselves, that they're a little bit of both, the hybrid. Anybody here a caregiver? A few people are. Who are the caregivers? The caregivers are spouses, adult children, children under the age of 18. The American Association of Caregiving Youth has said that there is somewhere between 1.3 million child caregivers aged between the ages of 8 and 18. Their center is in Boca Raton in Florida, and they're a very active organization and worth checking up on when you have a moment to look at them on the internet. Other relatives, friends, colleagues, neighbors. Very briefly, to make sure we're all on the same wavelength, what do caregivers do? They prepare food, they help feed the people who need the help, they do home cleaning and home maintenance, shopping for food, take care of the finances, provide physical support to move people in and out of bed, provide transfers, do the laundry, take care of hygiene and toileting, provide emotional and physical support, oversee medication use. They help their care receiver navigate the healthcare system, communicate with healthcare professionals, and very importantly, try to help things fall through the cracks. And at the bottom of both of those columns are question marks and lots of letters, meaning that there are lots of other things that caregivers do that I'm not going to identify, but I'm sure you can. A few statements about realism, and I'm going to quote some Canadian figures, but they are very equivalent to what occurs in the US. And when I quote a Canadian figure, multiply the factor by 10. That's the general rule of thumb. But for the most part, what I'm going to say applies locally as well. The Canadian Centre for Chronic Disease Prevention estimates that 1 in 2 Canadians will encounter chronic disease in their lifetime, either in themselves or in family members. This contradicts the traditional North American healthcare view, and the one that we often teach in medical school or nursing school, that we're actually a curative discipline. We are getting better at curing, but for reality, we don't cure too many diseases. We have learned to treat, and we've learned to maintain individuals longer and longer and healthier lives, and in doing that, the role of caregiving expands. True or false? Family caregiving is synonymous with looking after the elderly. Who says yes? Nobody. Okay. You all pass. How does that work? Well, children. Increasing numbers of premature infants are born and survive, and sometimes with complex illnesses that provide years of family care. There are infants with genetic abnormalities and inborn errors of metabolism who were previously poor survivors and are now living lifespans only hoped for. Children are born now to older mothers, and some of these have greater health problems and require follow-up both intellectually and physically. Adolescents and young adults. These are the people who engage most in high-risk activities, and therefore those who are most often the victims of accidents and violence. However, with improved emergency response, advanced trauma teams, outstanding improvements in nursing care and technology, post-trauma survival has significantly increased, but many who do survive have long-standing health limitations and chronicity. Young adults also unfortunately suffer from neurodegenerative diseases such as multiple sclerosis. You may be interested in that in many cities now, children's hospitals now have divisions for children with multiple sclerosis. Quite a shocking reality. In cancer care and oncology, there have been major ongoing advances in the medical and surgical oncology, which are associated with progressively longer survivals for many tumors. And as I think you're aware, cancer is generally viewed today as a chronic illness. In middle age is that lifespan period that sees the onset of illnesses that require increasing attention or the warning signs that problems are beginning to appear. Depending on who defines middle age, it starts somewhere around the age of 35 or 40 and goes up to about the age of 65. But it's during that period that we see the onset of coronary artery disease, heart failure, diabetes, strokes, autoimmune diseases, depression, and other mental health problems. And with better approaches, better drugs, these individuals are showing improved quality of life, improved survival, but again, many require family caregiving. Within the older adult population, the diseases that many of you are familiar with, you see the evolution of the existing illnesses that appeared in middle age. We have Alzheimer's disease and the related dementias, Parkinson's disease, and stroke, and I'm sure you can add to the list. Taking some characteristics of caregivers, and again, these are Canadian statistics, multiplied by 10. At least 3 million Canadians, or 10%, just over 10% of our population, identify themselves as caregivers, and of the caregivers, 2.3 million are employed outside of the home in the workforce. 1/4 of older workers in the workforce are caregivers, and within Canada, caregivers caregiving employees, that is people who work in the workforce but are caregivers at home, provide 893 million hours of care annually at home. A huge amount of hours. That results in the reality that their pay is reduced by some 2.2 million hours per week. They leave work, they have staggered hours, they don't provide the same workforce. By them working at home looking after their family members or friends, they're providing the equivalent of $25 billion of unpaid labor annually to the healthcare system. So multiply by 10, $250 billion here in the US. And that's the equivalent, again in Canada, of 157,000 full-time employees who are lost to productivity because they're looking after family members. What do we expect is going to happen as we look to the future as far as these family members are concerned? We are going to see in some areas labor shortages. Despite the recession, which is keeping people out of work, in due course people will get back into work. And talking from the more Canadian perspective, where we have not been hit nearly as hard with the recession, the labor shortages are not as bad. But with labor shortage, people are working longer hours and for more years because they have to make up the money they lost when they were out of work. When you are out of work, you still have to have the money to look after your families. Caregiving provides economic pressures, and the economic pressures of society, the recession, means lost wages, loss in investments, changes in pension entitlements. All of these are likely going to affect the age at which people had hoped to retire. And then we have the baby boomer generation, that 18-year gap between 1946 and a year and a half ago, and it's projected that baby boomers are not going to be all that enthusiastic about retirement. It's not part of their makeup. So let's look now at some consequences for caregiving, starting off at the emotional level. One of the first things that caregivers demonstrate is denial. They deny that there is a problem with their family member or friend, or that it is as bad as it actually is. They express anger. It's anger at others for not helping out, often at family members who are not doing the same amount of work that they are, angry at themselves for not being able to do more, and surprisingly, angry at the ill person for being ill. It's an irrational reality, but it's common. Continuing on the emotional reaction, caregivers bargain. They bargain for others to get help or some share of the burden. They bargain with you folks, with the health and social service professionals, to find other treatments and to do more and to supply more. They express in various forms depression, and that depression may be as simple as chronic fatigue, just dragging them down, or it may be a function of grieving the deterioration in somebody that they care for. There is acceptance at some point, and that's often when they're able to read the writing on the wall and see the reality of the situation in which they find themselves. And if any of you have followed the emotions that I've listed here, I've just picked these up from Elizabeth Kubler-Ross and her stages of grieving. They fit very, very appropriately into the caregiving situation. Caregivers show greater use of psychoactive medications. They're tense, they're tired, they ache, they're sad, they get medication. Physical consequences of caregiving. Caregivers present to you with new symptoms that are suggestive of altered health, and they show symptoms of stress that involve changes in sleep patterns, poor nutrition, which means often weight gain or weight loss. They have aches and pains that they can't explain and that occur in strange places. And they have more visits to their doctors for new or ill-defined problems. And overall, they have a decreased sense of well-being that is difficult to escape, and we're going to look at those. From the social perspective, the caregivers feel and complain about loss of personal time for themselves. The caregiver cry, Let me close the door, let me have quiet, let me have a few moments where I don't have to respond to you. I had to do that at work. I did that at supper time. I did that on the weekend. Now, give me 15 minutes just so that I can feel human again. Caregiving results in decreased ability to participate in normal daily routines. The phone call that says, "How would you like to go to a movie with me?" Sorry, I can't do that. I've got some responsibilities here, or I'm too far behind in writing the bills, or I have to go shopping. All of these activities may lead to some form of restriction of activity, which results in caregiver depression, and as I mentioned before, chronic illness manifestations. There is less contact with friends, as I've alluded to. At work, caregivers tend to be less effective. They may be more irritable at work, and they often work in a peer environment, a work environment where their friends are not understanding. And I can share with you that I have worked in a family medicine center for many, many years, where it's taken many years for my colleagues to be aware of some of the issues that I bring to work. And part of the reason for this is that this is a unit that I helped develop many years ago, and so I'm somewhat older than the majority of people in our unit, and they haven't quite felt the experience of being a caregiver. And reading it, sometimes reading about it, sometimes doesn't help. You need to have a little bit of experiential contact. Caregivers have a decrease in holidays, a decrease in away time, their financial worries mount, and of course there's the risk of abuse for care receivers. And that's why I led a team that helped develop the Elder Abuse Suspicion Index, which is a very simple 6-question tool to be asked of care receivers, the patients, to be asked by doctors, not to necessarily diagnose, but to get a level of suspicion great enough to justify suggesting that that individual either have a further discussion with you or a member of your healthcare team, or consider being referred to Adult Protective Services. What we did with this tool is we took it out of the realm of traditional social work, which for many years used lengthy inventories with indirect questions, and created a tool that allows for direct questions that people are comfortable understanding. They're comfortable understanding them from physicians and nurses when they weren't from social workers, because the relationship with the doctors over the years has created a situation in which patients become comfortable with the idea that doctors are going to ask personal or invasive questions. And that's one of the strengths of the tool. Caregivers present with sense of burden, and that burden is often associated with risky health behaviors. What does that mean? Alcoholism, gambling, fast driving, possibly extramarital affairs, and you can choose any other risky activity you like. Caregiver burden also correlates with caregivers perceiving that their physical and emotional health has gotten worse. It may not be worse, but they perceive it that way. And perception, as you know from your patients, is what is their reality. And despite the perception, Australian data shows very clearly that caregivers are more prone to physical injury, in particular back, neck, and shoulders. The biggest consequence of being a caregiver is mortality risk. Schultz and Beach in 1999 published what is a landmark paper in caregiving, and they showed that a link between caregiving and mortality risk. Specifically, elderly caregivers giving home support were 63% more likely to die than an elderly person who is a non-caregiver when followed over 4 years. So everything put together means that caregivers are at major risk for morbidity and mortality. It says we have to get to know who our caregivers are and to follow them perhaps in a different way and perhaps in a more proactive and more preventive way. In the United Kingdom, they have created a project in which, through funding from something called the Princess Royal Trust, they have been able to identify individuals and have them identify themselves as caregivers, identify who their general practitioner is, and each general practitioner receives a list of who his or her patients are that are caregivers, and these doctors are requested to, in a particular way, flag those charts and use certain strategies to start working a little bit more closely with caregivers in a preventative way rather than in a reactive way. Ethnicity plays a role. Ethnicity is defined by common history, language, values, beliefs, customs, place of origin, and specific caregiving roles. And those specific caregiving roles are often unique to particular cultures. Ethnic minority caregivers, when studied, report more care hours, fewer financial resources, less training to be a caregiver, and greater risk of physical injury. And I don't think that would be astounding to you folks here. Let's switch for a moment from caregivers to care receivers. How care receivers react to caregivers, how care receivers receive the help and support they get depends on a large number of variables. It depends on their ages. It depends on where they are in their own particular life cycle. It depends on the type of illness that they have and the prognosis of that illness. It's very heavily dependent on their past experience with illness and how they react to it. It is influenced by an ill person's ability to ask for help, and to ask for help in a way that is not perceived as being too demanding to the caregiver. It depends on a care receiver's ability to accept help. And many care receivers have difficulty with this, and so there's a tug and pull between I want to help you, I want your help, but I'm not going to take it. And it often depends on the pre-existing relationship that the caregiver and the care receiver had prior to illness. What was communication like? If there was conflict, how was it handled? Was it open communication? Was it the kind of thing where things went unsaid? And if things went unsaid when things were good, things are going to be even worse now that there's illness. So that gets into the idea of the communication style. Was it an open style before illness, or was it a closed style? If it's closed, it means that people aren't going to be honest with each other. They're not going to talk about what is troubling. If the caregiving care receiver relationship is going to work, there needs to be some ability of the care receiver to acknowledge that the caregiver actually has a burden, despite the fact that the care receiver has the illness. It takes courage on the part of a care receiver to be able to say, you look tired tonight, we can leave this to tomorrow, it doesn't have to be done. Or, you need a holiday, you're always with me. Perhaps you should take a break and get away for a week somewhere. I don't object, I understand. Working on that communication is extremely important. The ability of a care receiver to have an open ear to hear the caregiver perspectives without resentment or anger. In the best of scenarios, a caregiver should be able to say to a care receiver, you're driving me crazy. You ring that bell every 5 minutes. Isn't there a way we could work it out so that when you need the help, you could kind of batch it together so that I'm not running down the hall all the time? Or you call me at work, and I know you need to talk to me, but maybe we can plan times when you call me when I'm less busy and less stressed. Or maybe we can have some kind of code that we have that I can say, I'm busy and I can't talk to you, but I'm not going to say those words so you don't feel badly about it, but you know that I love you, care for you, and that I'll get back to you afterwards. How do caregivers function? How do they make decisions? We're going to talk about something called lines of tolerance, and there are 3 lines of tolerance, 3 levels of tolerance. Caregivers can function below a line of tolerance, and that means these are caregivers who look ahead and who plan, who accept help from others, and who track their own emotions fairly closely. They're alert to what's going on and are ready to face it. There are caregivers, on the other hand, who function right at the level of tolerance. They seek alternatives, but they have emotional difficulty implementing them. I know we have to bring help into the house to help. I know that there are agencies there to help me, but I just cannot take that step to make the phone call to get that person to interview. There are caregivers who function above the line of tolerance. These are the ones who take things a day at a time. They function in a chronic state of overload. They feel that decisions are made by others, not by them, or that decisions are made by the illness. And some of these individuals have difficulty with opinions that are expressed by helping groups out in the community, such as Alzheimer groups and equivalents. So we talk about seeking help, and we talked about those who know how to get the help, and then there are those who aren't quite ready. And so one of the things that interested me was to try to go through the literature and find out what it is that promotes caregiver readiness to act or to seek help, and what is it that inhibits the seeking of help. Not surprisingly, I found very little in the literature about factors that promote readiness. What does promote readiness are caregivers who realize that their health is getting worse, that they're making increased visits to doctors, they're taking more sick days off from work, they're suddenly on more medications, more comorbid illness, and they have worsening life satisfaction. Things are closing in on them suddenly and they're losing control. The other group that seems open to receiving some help are those who understand and accept the eventuality of decline. And that's all part of the grieving process of trying to come to grips with the disease, with their care recipient's illness, with their loved one's illness, and making peace to it to a degree that they can accept help from outside. The factors that inhibit, that discourage, prevent caregivers from seeking help. Initially, one of the most important is that caregivers need time. They need the opportunity to develop a narrative, to recount their stories, and to develop some meaning to their situation as caregivers. Until they understand that role, it's not easy to bring somebody in to help out. Some caregivers refuse or have difficulty identifying themselves as caregivers. One of the most common groups of individuals who do not identify themselves as caregivers are those who care for people with chronic depression. If you do the lit search on that, there are almost no studies on caregivers of depressed individuals, because the depressed individuals either don't allow you access to to their family members, or because the family members, when recruited into the studies, say categorically, I'm not a caregiver, I'm just a member of the family. Some caregivers will not accept help because they fear unwanted interventions. They fear bullying and harassment. That's bullying and harassment from us, from the health and social services sectors. Family conflict may come into play, disagreement by family members about the when, the how, the who of giving help. Some people have problems changing their routines. They've got a pattern set up. They're the best. They know best how to transfer their wife. They know best how to feed her. They know best when she needs to be put to sleep, and it's difficult releasing control. Readiness is also inhibited by absence of validation from someone or some organization that the steps that one are taking are normal steps, that it is something that anybody in your situation would do. There's fear of surrendering to the system. There's fear of permanency. If I do X, what's going to happen? So if I bring somebody in to help, is that the thin edge of the wedge that says this will last 6 months, and then we have to look at a nursing home, and from a nursing home to something else, and then to something else? People do need maps. They do need to understand the system, but they, in terms of the trajectory of the illness and where care can be given, but at the same time, it can be done in a gradual and gentle fashion so you're not being hit over the head. There's resistance as well to seeking help based on ethics, which is rooted in religion, prayer, and social norms. And there is a very strong literature here that have interviewed many people who are particularly observant, and they will, in their interviews, quote scripture that validates their roles of looking after the family and the importance of doing that and the worthiness of taking care of one's own as opposed to seeking help from others. And for some communities, that takes over, and caregivers are extremely reluctant to reject their religious teachings. Others refuse the help based on sense of debt to a family member, sense of duty, guilt, kinship, or reciprocity. He helped me when I was sick, she's going to help me now, etc. Tit for tat, got to help out. Low literacy, unfortunately, plays a huge role in not accepting help, and that much of the literature in many communities that we give individuals to help make decisions is not at a level that people can understand. So you're given the literature to read, but don't understand it. Or the resources that are offered, the timing of the resources, the location of the resources may not feel right at this particular time. And caregivers need the opportunity to ventilate those feelings that it's not the right time. I'm not against it, but I'm not ready for it. Come back to me in 2 months. Give me a chance to come to grips with it. I talked earlier about bullying and harassment. Some caregivers report concerns about the dominance of formal caregivers, that's all of us, or the negative approach of health professionals. That health professionals don't talk to caregivers and to families the way they want to be talked to, which leads to the last item on this particular slide. Why should I change just because you tell me that this is what I need to do? Caregivers and care receivers desperately need to understand how it is that a health professional arrives at the decision that he or she is making. You need to modify your home. You need to modify your bathroom. We're doing just fine, very well. We can do it. We're cleaning my husband up every day. We bring in help, etc. Yes, but you need to put in a special shower stall. We're not ready to put in the shower stall yet. We worked very hard on this bathroom. It was a construction of love many years ago. We're not breaking it up. Nobody is telling the family what's going to happen in the disease trajectory that's going to make the essential changes in that bathroom necessary. We talk from experience, but we don't share that experience because everybody, not everybody, some people are in a hurry, some people don't think sensitively enough to say, well, I'm hearing your discomfort with this, I see your discomfort with this, you look unhappy with what I'm saying. Perhaps we can talk a little bit about what that unhappiness is all about. Self-confidence comes into this in a large way in terms of accepting or not accepting. somebody who believes that they can do it and have always done it, may be that same person who says, I don't want your help. Up to this point in the listing of inhibiting factors, I've listed probably 15 reasons why care receivers may refuse help. One would like to do better and say, well, is there some kind of ranking, some kind of hierarchy? Unfortunately, it doesn't exist. A multivariate analysis of caregiver-care receiver relationship show that there is absolutely no consistency in how caregivers rank 12 motivations for change. So we as professionals need to be aware that there is a broad spectrum of reasons and problem solve with the patient and caregiver. Now we're getting a little bit towards the doctors. We talked about the caregivers, a little bit about the care receivers. What about the caregivers? Carol Levine in New York about 10 years ago wrote a paper about what caregivers want from their doctors, or nurses, or social workers. Just change the word around, and I think it fits for whoever's here today. They want individuals who are competent, available, and compassionate, who provide information in non-technical fashion, who can support the existential crisis that the caregiver and the care receiver are experiencing, who project positive body language and show positive gestures, who have courteous and helpful support staff. And I can't say enough about the support staff issue. The number of people in my practice who will come in and say, gee, your secretary, she's absolutely wonderful. I call, there's a laugh, there's a giggle, she makes me feel good. Or the one preceding her, she was a witch, had nothing nice to say to me, too busy, always putting me on hold, etc. We often work in work environments where we don't have control over the people who work for us, but we can sure try to put our efforts into the people who are part of our work environments. We want individuals who can speak both to the patient and the caregiver, and that the caregiver is not excluded in decision making. That does not mean that one breaches confidentiality. Clearly the care receiver has the right to make his or her decisions and is the first person that needs to be involved. But in the best scenarios are ones in which early on caregiver and care receiver are seen together, and one gets a chance to try to develop some sense as to what each of them is looking for and each of them needs, which can give some interesting problems that I'm going to describe right now. In a study that we did 10 years ago in Montreal, it's a study about how Montreal family doctors see their encounters with caregivers and care receivers. We had done a previous study in which we had studied caregivers of frail elderly, and they had some fairly unflattering things to say about a proportion of the doctors. So we felt if that was the case, let's find out what the doctors see as some of the problems. 63% of our doctors said that the caregivers and their care receivers have different agendas. Not surprising, but it suggests that there's conflict. 62% said that the patients were reluctant to use the resources that were suggested. Remember the comment I made earlier about maybe you suggest at the wrong time, maybe the patient isn't ready yet. Just about half said the caregiver and their care receiver have different or conflicting responses to the doctor's suggestions. Not surprising, the needs are different. 42% found that caregivers were reluctant to use community resources, and 31% said that the caregivers actually intruded into the care of the elderly patient. So what these statistics show is that, yes, we want to bring the caregiver and the care receiver together with the doctor, but there's going to be conflict. There's going to be difficulty. How much difficulty? In the study that we conducted, 81% of our family physicians were seeing an average of 20 patients a day, and they noted that encounters with family caregivers were stressful, and that as few as 3 encounters with a caregiver per day were enough to make them feel that the day had been particularly stressful. 3 was the magic number. Anything over 3, the doctor said the day wasn't worthwhile when they went home. It tells you how much conflict, how much pressure comes into the interaction because you're dealing with so many people's different needs. What about in Australia? Australia general practitioners appear to try to help caregivers, but are at a loss to respond to emotional needs. Lots of training is needed there, folks. If you do try to make a meaningful relationship between the doctor and the caregiver, does it make a difference? The data suggests, yes, that it mediates the stress of caregiving. There's a potential improvement in the quality of life of caregivers, and caregivers show improved mental functioning, and they perceive better care for the patient, and they report fewer behavioral problems on the part of the care receivers. There is a position paper that was published in 2009 by the American College of Physicians. This was a consensus report I believe, published in JAMA that had input from almost every medical discipline: urology, surgery, psychiatry, internal medicine, geriatrics, went right across the list. And there were about 15 different recommendations. I'm going to skim these very quickly because I want to leave time for questions. But effectively, this was the first time that there was a formal statement by the American College of Physicians that recognized that a doctor has a contribution to the caregiver's sense of importance and the potential of the caregiver experience. And the degree to which caregivers feel supported by doctors may influence how caregivers experience burden. And when doctors recognize the caregiver's physical, psychological, spiritual, and emotional needs, caregivers have less depression. The doctors can promote a family-centered approach while recognizing patient autonomy, privacy, dignity, value, rights, and confidentiality. That doctors can play roles in assisting caregivers to understand and accept the evolution of the patient's situation. Can give ongoing assessment of caregivers' well-being and concerns, and certainly encourage social service input and respite care. Promote people to start thinking about levels of care, end-of-life issues, particular sensitivity to cultural and family values. And when there is conflict, consider it, when there's conflict or when one has a particular professional difficulty, consider bringing in an ethicist, a bioethicist, a medical ethicist, to help sort things out. Don't take it all on yourselves. Provide clear and consistent information about the patient's condition. Avoid jargon, avoid repetition. When a caregiver happens to be a health professional, they need to be treated differently. They needs to be recognized that we come with different information, different expectations, different baggage. We need it to be talked to differently. We need to be considered part of the team, but not somebody who is there on a daily basis writing orders. Family members who are health professionals can provide particularly important input into improving continuity of care and minimizing the risks of falling through the cracks in a growing fragmented medical system. Do doctors play these roles? Studies in the US, Canada, France suggest that in general, doctors are not sufficiently involved or interested in responding to caregivers. The implication is that physicians need better education about caregiving both in medical school and in residency programs, and that education should not be restricted solely to a geriatric or family medicine rotation, but should occur on all rotations. Rosalind Carter, former First Lady, said that there are only four kinds of people in this world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. So in conclusion, family caregiving presents challenges for caregiver, for care receiver, and for physician. The interface between these three, as I have suggested, does not come naturally and requires a lot of work and openness. And consistent with the collaborative care model of chronic illness, all three clearly have roles to play to ensure that the best outcomes are going to be achieved for all three: caregiver, care recipient, and physician, or other health professionals. Thank you.
You undoubtedly have questions of Dr. Yaffe, and you can direct those, and he will repeat the question for the benefit of the camera and the recorders. Any questions?
Yes.
You mentioned that physicians find that dealing with just 3 caregivers in a day is a really stressful thing for them. I'm recalling my training days and et cetera. What the times when I found I was the most stressed was when I didn't really feel I had anything to offer that was meaningful in any way. I'm imagining that the resources available in Canada are different from what there is in the States, and I imagine there's huge variation geographically from one part of a country to another. But you know, when someone comes in and they have no financial resources, and we know that there are cutbacks, at least in the States, on all kinds of services, it's hard to really imagine what we can meaningfully do. So do you have any comments on that?
The question pertains to what do you do when you feel you have nothing to offer, either as an individual or because the system doesn't support you in doing what you'd like. Firstly, let me debunk a myth. We have the same problems you have. They're just different in varying ways. So the question is very relevant. I think the first thing is to recognize that all solutions do not rest with us the moment that they walk into our doors. And that in many cases, I'm not convinced that they are necessarily, they being the families, necessarily expecting that we're going to come up with all of the answers. But what the literature says, and what I think the experience of most experienced clinicians says, is that if you give of yourself in terms of your humanity, your caring, your time, your listening, your empathy, the occasional touch on the shoulder, a smile, perhaps even some cautious disclosure that says, yes, I can relate to that, I'm a caregiver too. Any of those things go miles to allow individuals to walk out of the room a little bit less burdened and allow the health professional a little bit of time to see if he or she can come up with some particular solutions, and to recognize that we don't practice in a vacuum, that we have people that we can turn to. It may take much longer than we would like. We'd like the solution in a week, and it's going to take 6 months. Well, if it's going to take 6 months, then I'm going to be seeing that patient and caregiver much more frequently during that 6-month period. Not an easy one, but there are many other situations where we're also, as health professionals, left with a certain degree of impotence, and much of what we have to give the patient is ourselves, the doctor, the nurse as the therapeutic agent.
There was a question here, yes.
I'm interested in the case of dementia, and I wondered what you think the biggest difference is in working with the team, with the physician, the caregiver, and the person with dementia. What's the most important thing we should remember?
You're asking what the most important thing is that the treating team should remember about dementia? and working with the person with dementia. I would say that the unique aspect of dementia, of Alzheimer's and related dementias, is that we all want to have verbal and meaningful contact with the people we are caring for. And we lose that when we're caring for people with dementia. And the importance of memory, the importance of narrative, of family story, of pictures, movies, to remind one of what the family member was like years ago. People tend to do this after people die, at funerals. Pictures are pulled out and they look and, you know, oh, the family's having a wonderful time. You need this much earlier on. You need this to remember it's not her fault, it's not his fault. This is the person that I care for, this is the person that I love. But I've forgotten who that person is because the person in front of me is not that person. And so you've lost that emotional bond. I encourage them to try to regain that emotional bond through memory, through pictures, through stories, through sharing experiences of the past with other family members. I think that's probably the strongest way to survive the experience. Yes?
Two things. One, in follow-up to that, there was an article in the Courier Journal this morning that spoke to the wonderful thing that ESPN has done for Pat Summitt-Head. They put together a video of her life working with her son, and she was quoted as saying, not only will this help my son and my friends remember me, it will help me remember me, which was pretty compelling. But my question is, it's pretty clear, the data speak for themselves, what needs to happen with the curriculum to make sure that all the health science professions address this issue. Have you been successful in Canada, you know where I'm going with this, in getting this included in all of the health science curricula in Canada?
The question is an important one, and it was, have we been successful in Canada in incorporating within the curriculum issues pertaining to caregiving? I would share with you that about, I'm going to say 10 years ago, I may be a little bit off on the timing, this was something very dear to my heart, and I surveyed the we have 17 medical schools in Canada. I surveyed the associate deans for undergraduate education to ask them what it was that they were teaching on family caregiving in terms of where was it taught, were there written objectives, how many hours were devoted to it, and in what years this took place. Of the schools, I ultimately got 10 responses only by actually getting on the telephone and sort of making the respondents a little bit embarrassed, and did the survey over the telephone. And of the 10, only 3 had anything of any note, and there was nothing more than up to about an hour and a half, and usually during a geriatric or pediatric experience. Having said that, gains have been made. The article that I reported in JAMA is the foundation for what medical schools in the U.S. should be now doing, because it has been defined by the American College of Physicians as being an important part of our curriculum. In my own medical school, we're for the umpteenth time introducing a new umpteenth time, that's unfair. Every medical school should periodically renew their curriculum. We are just completing a curricular change. There will be some caregiving introduced. I had requested a 2-hour block to be able to talk about some of the things that I've talked about today and expand on them. To the best of my knowledge, we're not getting those 2 hours. We may get an hour, and I'm not sure who's going to be teaching it or in what context. So we've got a long way to go because there are still a tremendous number of assumptions being made that caregiving is an intuitive thing that everybody thinks about. And then the final comment on your question is it's one thing to teach it, but if you aren't going to role model it on the wards, at the teachers in the family medicine centers or wherever the ambulatory services are not going to role model it, the teaching goes nowhere. And we've experienced in our faculty that we've introduced all sorts of new things into the curriculum, but know that the trainees tell us that the role modeling isn't there. And so they get the information, but don't see how to apply it.
May I raise a question?
Absolutely.
In my experience, which is basically rural in America, it seems to me that the critical factor in caregiving is with the caregiver, most of which have the most significant factor of their role as being availability. Not training, not competence, but availability. And that falls through the hole of how then do we access training for this group of people. And there is no training. It's simply that we think that perhaps by past experience they will be able to care for our family member in our absence. Does that make sense in your experience? And do you know how we can address that?
The question would be how to address the fact that in rural sites the caregivers are predominantly people in the home, and how do we assume that they have the skills, and if they don't have the skills, how do they get them? We have the same problems in Canada for this. I think the best model that I have seen, again, goes back to the United Kingdom, where there are far and away, in my opinion, some of the most outstanding government-sponsored organizations and employees who go into the home with various objectives. One might be as a homemaker, but if you're going in as a homemaker, you're going in to not only do, but to teach. If you're going in as a nurse, you are going in as a nurse to do a procedure, but also as best one can to teach the family member what is going to be necessary. So it expands the notion that services that we provide to the families is solely instrumental, whereas I think that a lot of it has to be educational, and along with it being educational, availability by phone to answer questions as they come up, and periodic visits into the homes to make sure that the caregivers aren't burning out and that some respite is offered.
Unfortunately, we must also attend to our contract with the clock. There are other responsibilities to which we must attend, and we appreciate Dr. Yaffe's being here. Would you join me, please, in expressing our appreciation?